Good afternoon, everyone, and welcome to Health Reform Beyond the Basics. Thank you for joining us for another office hour session. Today's session is Plan Design and Plan Comparison. I'm Ayesat Odiale, the Health Projects Assistant at the Center on Budget and Policy Priorities, and I will be moderating today's webinar. Beyond the Basics is a project of the Center on Budget. It's designed to provide training and resources to facilitate enrollment in the ACA health insurance marketplaces and Medicaid. The Center on Budget is a nonprofit policy organization. We are not a part of the U.S. Department of Health and Human Services. Beyond the Basics is aimed at healthcare assisters, advocates, state and local officials, and others who help people get and keep their health coverage. This session is not intended for press purposes, and we are not able to offer continuing education credit for our webinars at this time. Webinar logistics. So automated captions have been enabled for this webinar. To view them, you can click on the CC icon or the More option with 3 dots at the bottom of your screen. There you will be able to have the option to turn on closed captioning. And all participants are muted and you are in listen-only mode. If you would like to ask a question, you can put it in the Q&A chat. Clicking on the bottom of your screen, you'll see the Q&A icon, and there you can type in your question. And throughout the webinar, you can actually upvote questions in the Q&A chat. You do this by clicking on the thumbs up under a question you like, and this will bring the question to the top of the Q&A chat. The questions will be monitored throughout the session, and we will be dedicating a majority of the time to Q&A. We may not be able to answer every question that is asked, but we will try our best to get back to you after the webinar, and we will have a record of the questions asked, which will guide us for future resources and presentations. And just a quick reminder that you will not be able to click on the screen to go to any of the links shared in the deck, but I will put a link to the full slide deck in the chat. Here's the webinar schedule for our fall series. We've been hosting a combination of traditional webinars and holding office hour sessions for topics where not much has changed. We've hosted full-length webinars on topics with new information to share. We are almost at the end of our series. Next week, we'll hold office hours on the auto renewal process, and we are ending with our first ever trivia challenge, which will put your enrollment skills to the test. Today's agenda includes about a 20-minute crash course on plan design and plan comparison, followed by a live Q&A session. We've queued up frequently asked questions, and as I mentioned, we will take questions via the Q&A chat. Our presenters are Claire Heyison, Senior Policy Analyst on the CBPP Health Team. Claire specializes in health insurance and marketplace policy. And Arianna Anaya. Arianna previously served as a certified application counselor, community health worker, and navigator in Texas and Illinois between 2014 and 2022. And she has been presenting for Beyond the Basics since 2021. And we are joined by Lynn Cowles, Health and Food Justice Programs Manager at Every Texan, and former Navigator Program Manager, who will be helping monitor and answering questions throughout the session. So with that being said, I will pass it to Claire to kick us off.
Thank you, Ayesat, and welcome everyone. We're so glad you've joined us today for this office hour session on plan design and comparison. As Ayesat said, we'll spend most of the next hour responding to your questions, but first, Arianna and I are going to provide a quick crash course on some plan design and comparison basics. This presentation is not going to get into the weeds on any of these concepts, so please feel free to ask any clarifying questions during the Q&A. And you can also reference last year's Beyond the Basics webinars for a more in-depth exploration of these topics. And here they are. Oh, sorry. We will start with the definition of a qualified health plan. So qualified health plans, or QHPs, are insurance plans that must meet certain standards and include consumer protections outlined in the Affordable Care Act. These include having coverage for pre-existing conditions, covering the 10 essential health benefits, or EHB, having cost-sharing limits that follow federal regulations, and not having any annual or lifetime limits on benefits. QHPs must also be certified by the Federal Health Insurance Marketplace or a state-based marketplace. These are the 10 EHBs, or essential health benefits, that all QHPs must cover under the ACA. Those benefits include preventive care, hospital care, prescriptions, medications, maternity care, pediatric care, and more, as you can see here. Another important element of all health plans, including QHPs, is the plan network. A plan's network is made up of all of the physicians, hospitals, and pharmacies that have contracted with the plan to provide services to enrollees. Providers the insurance company does not contract with are considered out-of-network. And while some plans will cover services that the enrollee receives from out-of-network providers, the enrollee will usually have to pay more out of pocket than they would if they went to an in-network provider. And some plans won't cover any services received from an out-of-network provider at all, except in cases of a medical emergency. So it's very important to know that every plan has its own network, and even plans offered by the same insurer can have different networks. These are the different network types you'll see in the ACA marketplace. Some of these network types may not be available in every area. So for example, in your area, you might see HMO and EPO plans, but not POS and PPO. In general, the factors that differentiate these network types are number one, whether the plan requires enrollees to get a referral from a primary care provider before seeing a specialist, and two, whether the plan will reimburse enrollees who receive routine care from out-of-network providers. All marketplace plans must reimburse out-of-network emergency care at in-network rates and cannot balance bill enrollees for these services. So next we will talk about formularies. Formularies are a list of medications that an insurance plan will pay for. The formulary splits up covered medications into categories or tiers to indicate the level of coverage that the plan provides and the portion of cost that the enrollee will have to pay for various medications. The higher the tier of the medication, the more the enrollee will likely have to pay out of pocket. And generic medications are usually in the lowest tier, which means the enrollee will pay the least for these medications. Medications that are not listed in the formulary are generally not covered by the plan, although exceptions may apply. So we've covered plan benefits, networks, and formularies. Now we're going to spend the rest of this, or the rest of my section of this intro presentation talking about cost. So there are two main categories to be aware of when it comes to plan cost. The first is the premium, which is the monthly cost that a person pays to their health insurance company for their health insurance plan. Premiums must be paid every month or the person's plan may be terminated. The second category is cost-sharing charges. So these are things like deductibles, co-payments, co-insurance, and the out-of-pocket maximum. These are all the costs that a person pays to healthcare providers as they use healthcare services that are covered by their insurance plan. And we'll talk about each of those types of cost-sharing charges a bit later in this presentation. As you may know, there are 4 metal levels of QHPs: bronze, silver, gold, and platinum. Each metal level corresponds to a different actuarial value, or AV. AV is a measure of the percentage of in-network covered benefits that a plan expects to pay for over the course of a year for a standard population. So importantly, we're talking about over the course of a whole year when we're talking about a standard population. So when we're talking about AV, that's not going to be the percent that a particular person is going to pay for a particular service. It's an average over the course of a year for a standard population. What's important to understand is that enrollees will typically pay more in premiums for plans with higher AV, like Platinum or Gold, but they will also pay less out of pocket when they need care. And the reverse is true for Silver and Bronze. Typically, those will have lower premiums, but also higher out-of-pocket costs relatively. For people with lower incomes, though, that calculation differs a bit. So people with lower incomes are eligible for cost sharing reductions, which can greatly reduce their out-of-pocket costs. In order to receive cost sharing reductions or CSRs, a person has to have income at or below 250% FPL. So that's around $38,000 for a household of one or $78,000 for a household of four. And the lower a person's income is, the more help they receive in CSRs. The person, importantly, also has to enroll in a silver plan in order to receive CSRs. As you can see in the chart at the bottom of the screen, if someone with an annual household income between 100 to 150% FPL enrolls in a silver plan, that plan will have 94% AV. For people with income above 150% FPL and at or below 200% FPL, their silver plan will have 87% AV. And for people with income above 200% FPL and at or below 250% FPL, their silver plan will have 73% AV. The key takeaway here is that people with income at or below 200% of the federal poverty level can get coverage similar to a platinum plan at silver plan prices. So recall that the AV for a platinum plan is 90%, for gold it's 80%, and for silver, if you're not eligible for CSRs, it is 70%. So if you are a person with income below 200% FPL, you can enroll in a silver plan and get coverage that is as generous or like around as generous as a platinum plan. Unlike the premium tax credit, which the government pays for and which people have to reconcile at tax time, insurers build CSRs directly into their plans. If someone is eligible for CSRs, all they need to do to enroll in a silver plan to receive those savings, all they have to do is enroll in a silver plan to receive those savings. There aren't any extra steps to worry about. As you can see on the right, if a person is eligible for CSRs, healthcare.gov will flag silver plans with that orange extra savings icon. And finally, I wanted to briefly mention that there are additional cost savings for members of federally recognized Native American tribes and Alaska Claims Settlement Act corporation shareholders, sometimes referred to as American Indians and Alaska Natives, or AIAN. So for AIAN people with income between 100 and 300% FPL who qualify for the PTC or premium tax credit, plans with zero cost sharing are available. For AIAN people with incomes out of that range, so below 100% FPL or above 300% FPL, there's a limited cost sharing plan available. And I believe under that plan, enrollees are eligible for $0 cost sharing if they receive services at an IHS facility or receive a referral from an IHS provider. So now that we have all of that covered, I will pass it over to Arianna.
Thank you so much, Claire. All right. So I'm going to focus today primarily on talking about health plan education and ensuring that sisters out there have something of a script to assist individuals with picking a plan. So first and foremost, I always want to talk about the filter tool because I think it's easy to overlook and just start scrolling through plans. But I think that your best bet is absolutely to click on the filter tool, which is up in that kind of mid left-hand corner of the screen right there and now highlighted with that yellow band. What the filter tool will do is pull open some opportunities that are not as helpful and some that are exceedingly helpful when it comes to screening through different plans. However, I think the most useful part of this is got to be the information that's laid out. You've just gone through a very long application in which the client kind of had to take the lead. And now you need to shift that. You need to sort of be the person who's leading the education here because you, of course, have a lot of information on how health insurance works. So when I open the filter tool, I like to highlight certain elements and kind of provide the client with an overview of what their options look like. And sometimes I'll write it down. So the spaces from which I kind of glean that information are this health plan category section, and then to the right, health plan types. Claire pointed out earlier that there are 4 different plan types. Here we know that only 2 are offered within the specific market, only 2 of those 4 plan types, HMOs and EPOs. The final category that I find, I think, the most helpful is going to be a list of all the different insurance companies in a certain area. So being able to immediately know that, right, to glance at a list rather than having to scroll through plan after plan and kind of guess is really, really going to be helpful to you and to the consumer, especially if they have opinions on plans or if they had one last year and they're interested in the same company or they don't want the same company. You almost have an easy answer built right into the information that the filter contains. And so to summarize it, oh, and I should have shown that first, sorry. So here would be that list, of course, and this is in Miami, Florida, and they have quite a few different covers or insurers or issuers. So it's a long, long list. But a summary of that information is something that I created right to the right. And this is something you could be writing down kind of with the client and for the client to give them a sense of what there is to go through. And I think this can be helpful because you're able to show them that you know where things are, that you kind of have the keys to the castle, as it were. But it kind of helps the client understand that there's this wealth of options and that you are the guide who's going to help them with navigating that. So what I recommend for those of you in states that have healthcare.gov is to start with the least expensive silver easy pricing plan for your area. And I wanted to spend a little time talking about easy pricing plans, but I did also want to flag the fact that Center on Budget does have a 1-pager that kind of gets into them a little more. I just put it in the chat. Thank you. Essentially, it's almost as though if you can imagine every single car company that exists being required to offer a car that is the equivalent of all other cars offered by the companies. So a standard car where everything is effectively the same except, let's say, cost. Maybe this analogy isn't great, but the idea here is it really, really helps with choice to have a swath of plans that are essentially identical when it comes to how their cost sharing is governed. So how the deductible out of pocket, copays, and coinsurance are. They all must be identical. And the trick here is that this is an obligation that any health insurance company offering at least one type of plan in one metal level is required to offer one standardized plan that, of course, is the same as all the other standardized plans. So you're managing to essentially explain a bunch of plans by just explaining one easy pricing or standardized plans. So the parameters for easy pricing plans are going to change and be adjusted each year. This is the information on the 2025 easy pricing plans. So if we zero in on the silver plans, we can see at the 94% cost sharing reduction level, a deductible of 0, and then an out-of-pocket limitation of 2,000. So that means every company for 2025 is going to have to offer a plan like that for individuals eligible for that 94% cost sharing. So that's incredibly, incredibly useful. It also means, even though plans are probably not going to be released for at least another week or so, we already have information about plans that will be available for 2025, which is kind of a wonderful thing because that didn't used to be the case. Okay, so moving back to our amazing friendly neighborhood filter tool. If you actually click on one of the categories available, and of course, depending on your market, you might not see platinum plans. Um, but let's say you're going to follow my advice and you're going to start with the silver plans. There's actually a very straightforward way underneath that that will pop open to indicate that you want to look at the easy pricing silver plans. And you can see, even more helpful, we know how many silver plans total there are versus how many easy pricing plans are. So we kind of know that in explaining one of these, we're explaining 14 other plans. So I filtered for that least expensive, easy pricing silver plan and pulled up this specific Aetna plan. We can see that extra savings icon that Claire mentioned earlier, indicating that this is a plan with those cost sharing reductions, as well as that easy pricing label, which will appear on every single plan in that category. So, in case you're the very observant type and you notice that this deductible and out of pocket max do not match anything on the 2025 list of those parameters, this is because unfortunately I can't access 2025 plans until they're released. So, we're using older plans at this time. So, this would represent an older plan, easy pricing parameter model. So, once you have your plan education plan, I kind of operate from a left to right education um, model, for lack of a better word. So I like to start with the premium, then I move to deductible and out of pocket max. And I'm here going to include pretty literally the script I have tended to use when it comes to providing this plan education, that you pay the premium each month. I like to emphasize that you must pay it even if you don't use the health insurance, sometimes comparing it to a gym membership, right? Because that's not always known. Explain as well that the financial assistance has already been applied. And so the amount they're looking at is their responsibility rather than the full price of the plan. Next, we want to explain the deductible. Note that I say for certain care. I really ask that we are careful when we explain deductible, because Americans do seem to know that a deductible is a bad word and a scary limitation when it comes to cost. But they don't always know that there are other care categories for which you don't have to worry about the deductible. So it's not a bad thing to emphasize in this moment. Likewise, explaining the out-of-pocket max is to help the clients understand, really the function of health insurance, which is to protect you in case of a medical emergency. Your health, yes, but especially your finances. I think we used to say protect your health and your wealth, but I don't think we say that anymore. So in any case, that's kind of your big three from left to right. And now we're going to go a little lower on the page, and we're going to talk about the copays. So immediately explaining that the plan has copays for primary and specialist visits and generic medications, that you do not have to pay your deductible before those services are covered at that flat rate, is helpful and can relieve potentially client anxiety about the deductible. So I really recommend emphasizing this. Don't just say you pay 20, say you pay 20, and even take a cue from the marketplace's newer script from day one, regardless as to whether or not you've met your deductible. That's a flat rate, and that'll be the case up until you hit your out of pocket max. This can really help a client understand what they're looking at and how this plan works for them. The nice thing about the adjustments to this UPay section is that it tends to include the emergency room cost sharing, and that tends to be a co-insurance. So you can use this to explain the kind of unknown of how the deductible works and interacts with the co-insurance and interacts with the out-of-pocket max. So that can be a very useful element. I like to give a scenario, and I like to give a scenario because I've found that I'm always surprised by what the people I work with do and don't know. And often the cost of health insurance is something that people are simply not on the same page about. They don't understand what care, what health insurance, what, an out-of-pocket emergency. They don't necessarily have a good sense of the actual dollar amount and how high it can be. So I tend to, at this point, quickly run down a scenario that encapsulates dealing with a deductible and also a coinsurance. So let's say the first use is an emergency room visit. Then you're going to be responsible, of course, for that $800 deductible. And this is a good moment if they have questions or concerns to let them know that $800 for an emergency room visit is unfortunately pretty low. Let's say ultimately that ER visit results in bills totaling about 10 grand. And I highly recommend do this math with them if it seems like they're extra interested or they really, really want to get a sense of this. If they're tuning you out, don't. That's okay. Just make sure you set it. So your cost, right, is going to be that 10 grand for the emergency visit. You're going to be responsible for $800 of that amount and then 30% of the remainder. So that becomes 9,200. 30% of that would be 2,760. So that makes your total 3,560. However, and now we get to emphasize the benefit of this plan in terms of the out-of-pocket max. At this point, you'll have hit your max. And for the remainder of the year, all in-network and covered care will be paid for by the health insurance company. Now, you do want to make sure you say in network and covered care, of course, because even if the plan offers out of network care, there's a separate out of network deductible for it, right? So make sure you say that. Likewise, we've seen situations where clients understand that, okay, well, I've hit my max. I'm going to do whatever I want when it comes to care related things. A nose job is not covered. Any kind of cosmetic surgery is never going to be covered, whether or not you've hit your out of pocket max. So it is important to make sure you emphasize that covered care piece. And also, not a bad moment to reiterate that they must continue to pay their premium. Okay, this next section is very short. We're about to get to your questions, but a question I feel I get a lot has to do with how do we help clients really do this? How do we pick a plan? And as Claire mentioned earlier, we do have websites where we go into this quite in depth. But I think it is very important to understand plan selection as a balancing act of what the costs are, and that means the costs of care. But that also means the premium, right? Sometimes clients do have to make a decision completely based, or to some extent based on what they can afford to pay per month. And then they have to sort of balance that with what their care needs are. And then secondarily, the network, right? I think we found that there are plenty of moments in time where the places a client wants to go or the specific physician they want to see doesn't contract with marketplace plans, doesn't contract with plans at all, or is simply out of network in the plan that would be most expensive. So it's not a terrible thing to let clients know about this balancing act, that we're essentially looking for that happy medium between what's going to be reasonably affordable for them, not just when it comes to cost, but also when it comes to care, and where optimally they would like to be able to make use of that plan, right? It doesn't mean we're going to get it all, but we're going to get as much as we can in this balancing act. Here we've kind of outlined where different pieces of information are within a standard plan. Pulling that out for a client to some extent, right? When it comes to looking at, how do I know what plan type this is, right? What is an HMO, as Claire has gone over earlier, making sure y'all are familiar with that easy pricing label. And then also that view plan details, kind of to the right-hand side, is where you gain access to things like the summary of benefits, the drug medication cost, also called the formulary, and just a little more detail if you need it to buttress the information that's here. And, I did try and pull out the little chart at the bottom that gives you the overview of what the costs are associated with this plan, because that is an important thing for the client to walk away from it knowing. And then, of course, that plan details section is where you can access the provider directory and potentially take a look at the formula, or excuse me, the different providers and facilities that the client would be interested in. So, pulling again the standardized options, I think one thing that can be a little confusing is when do we actually look at gold plans? And I think it's confusing because so many of our clients are of an income that makes them eligible for cost sharing. So, obviously, if they're getting more value from a silver cost sharing, why would anyone look at silver? And the answer is, in certain circumstances, they probably wouldn't. And generally speaking, I would say if income puts them eligible for this 73% cost sharing reductions, and you can see the actuarial value, you can see the deductible, the out of pocket max. When you compare it to the gold, you can envision the person who might opt to pay more in the gold category for a lower deductible, for example, for lower copays for primary and specialists. So, somebody who's only eligible for the 73% cost sharing reductions may want to look at gold plans if they want lower care costs but don't mind a higher premium. And because generally these individuals will have a bit more income than those eligible for cost sharing at 87 or 94%, that it is possible, right? It does happen. It probably, meanwhile, of course, would not make any sense to show a person gold plans when they're eligible for 87 or 94% cost sharing reductions because you're paying more for literally less. And I hope this is especially evident when we look at the gold deductible of 1,500 versus the 94% cost sharing reduction deductible of zero. Obviously, zero, we can agree, is less than 1,500. And moving over to the 87% cost sharing reduction column, 500 is, of course, less than 1,500 as well. So often a client will say, well, wait, I want to see gold plans just because gold sounds good, right? I want to see gold plans. Who doesn't want gold? I want gold. But let them know. And you can just show them the first gold plan and maybe compare it to one of the silver plans that this costs more. And in fact, the value when it comes to the cost of care is not as high as what you're eligible for with silver. So that's sometimes a quick way to defray that question for clients who hear the word gold and are like, well, show me the gold. Okay, that should be it for my section. And now we're at question and answer.
Thanks so much, Arianna. So yes, we can use the remainder of this time to answer questions. So if you have any questions or if you'd like clarification on any of the concepts we went over, please type those into the Q&A box. So I will start with a question from Donna. I've seen gold plans priced cheaper than silver plans due to silver loading by carriers. So I guess less of a question, more of something to be aware of. And yes, this can happen. Certain states have specific rules on how they want issuers in the ACA marketplace to price their plans. And as a result of those plans, sometimes you will start to see some overlap between premiums for bronze and silver or silver and gold plans. So sometimes gold will cost less than silver, bronze will cost more than silver. I would say that that is just something to be aware of as you're going over plans with clients. But it should be pretty evident that if you're shopping or if you're helping the client shop and you're trying to get them a lower premium plan, if that so happens to be a silver plan as opposed to a bronze plan, assuming they're not eligible for CSRs, or I guess even if they are, but that might be like a better option for them, even though you might think it would cost more because of the name of the metal level. Okay, next question is from Emily. Can you explain integrated versus embedded deductibles? So an embedded deductible is a deductible it's relevant for a family plan. And basically what it's saying is, or what the case is in a plan with an embedded deductible, is that you have to reach an individual's out-of-pocket maximum, and then the family out-of-pocket maximum. So if you have like a two-person family, John and Jane, they're both enrolled in the same health plan with an embedded deductible. They will each have an individual deductible and then a family deductible. If John reaches his individual deductible, he will at that point, he will at that point have his plan kick in and pay for part of the cost and be responsible for copays and coinsurance that go along with the health services or medications that he receives. But because the family out-of-pocket deductible has not yet been met, Jane will still have to pay for her medications and her health services at the pre-deductible rate until she reaches that family out-of-pocket maximum. An integrated deductible is a little bit of a different concept. So that refers to the split. Some plans will have a separate deductible for medical costs, so health services, and then a deductible for prescription drugs. So that would be sometimes referred to as a split deductible. In an integrated deductible, there is one deductible that encompasses both prescription drugs and medical costs. Hope that helps answer your question. Okay. Aza Ahmed says, why in the state of Michigan are there no platinum plans? Issuers are able to choose not to offer them. And in some states, they feel that it is not worth it for them to offer a platinum plan. That's unfortunately the best answer I can give you. I know it's probably not a satisfying one. I also wanted to take this time to go over some of the questions that Lynn helpfully already answered in the chat, because I think that they speak to important concepts. So the first is, could you please extend the information about the difference between the types of plans like HMO, EPO, etc.? And so I'm going to try to navigate back to the slide where we talk about that. Here we go. So these are the 4 types of plans that you might see in the ACA marketplace. We'll start with the HMO. So HMOs might require the enrollee to have a primary care provider and might require a referral from that primary care provider in order for that person to see a specialist. For some people, this may not be a big deal. For others, for example, maybe they're seeing a lot of specialists. This might be a hurdle that they don't want to deal with. And HMOs only cover care that is received by that is provided by in-network providers. Out-of-network routine care is going to be 100% of the enrollee's responsibility. The EPO similarly does not cover out-of-network routine care, but unlike the HMO, they don't require a PCP or a referral to see a specialist. POS plans or point of service plans, similar to the HMO, they may require a primary care provider and may require that provider to give referrals for specialist care. But they do cover some care out of network, although usually with a separate higher deductible and cost sharing. So it is always going to be more expensive to receive out-of-network care, but for a POS plan, the plan is covering part of that care. And then finally, for the PPO, similar to the POS, they do cover some of the cost of out-of-network care, but don't require a primary care provider or a referral to see specialists. Another question I wanted to go over is, how will you know within the plans if providers are on a tiered level and what the office visit copay will be for the client? I'll just stick on this slide. So it's a great question. Healthcare.gov does have a provider lookup tool that you can use to see if a provider is in the plan's network. But some plans have tiered networks where you pay a lower cost sharing for providers on lower tiers, and higher cost sharing for providers on higher tiers, even though all of those providers are in the plan's network. So usually the kind of overview page, the comparison page on healthcare.gov will not provide the amount that specific that enrollees will need to pay to see specific in-network clinicians for plans with a tiered network. They'll just say if the provider is covered or if it's not covered under the plan. If you are looking for cost information, as Lynn said, the plan's summary of benefit and coverage, which is linked under plan documents, is probably the best place to go. Often these days, plans summaries of benefits and coverage will also include some kind of link or information about where to, like a link to the plan's website where you can look at the plan's network, search by specific providers, and then if the plan has a tiered network, see which tier the specific provider is on. And this question also, I think, applies really well to questions about prescription drug costs. The healthcare.gov prescription drug lookup tool will say whether a particular drug is covered by the plan or not, but it will not tell you what tier it's in or how much an enrollee can plan to pay out of pocket for that drug. So if you want that information, you'll need to go under plan documents and look for typically the formulary. Sometimes the summary of benefits and coverage will have that information as well. I will keep an eye. Oh, here we go. One more question. Is the copay deducted from the deductible? So typically there's kind of two answers to this question. If you have already hit your deductible, then no, because you've already paid enough of your copay to have that not apply. But your cost sharing would apply to your out-of-pocket maximum. If it's before your deductible, you probably wouldn't be paying a copay unless it's for a service, like Ari mentioned, that says, it's covered from day one. Those are also sometimes called pre-deductible services or pre-deductible coverage. So typically, if you have not reached your deductible, you are responsible for the entire cost of the healthcare that you receive. But importantly, for plans that do offer coverage for specific services or prescription drugs from day one, those copays are not going to count toward your deductible. They are exempt from the deductible. However, kind of confusingly, they will still count toward your out-of-pocket maximum. I realize that's confusing, so I'll go over it just one more time. If the plan offers services from day one, copays for those services will not count toward the deductible. If you are in the pre-deductible phase, typically you are responsible for 100% of the cost of your care until you reach your deductible. And then, so the costs will count toward the deductible, but it won't necessarily be a copay. And then after you've reached your deductible, the costs will count toward your out-of-pocket maximum, but not toward your deductible. Hope that helps.
And Claire, I'll just jump in really quickly. I would say briefly as I can, and basically, whether copays are going towards or not should be very specifically outlined in the plan. So the way we were looking at a plan that said from day one, those are completely independent of the deductible. But any copay that's paid, that goes towards the out-of-pocket max. I hope that helps.
Thank you so much, Arianna. Okay, as we wait for more questions to roll in, I am going to navigate us toward our FAQ page. Apologies for the dizzying advancing of the slides. I don't have a great way to jump toward the end of the presentation. Here we are. So one FAQ that we receive is, can there be limits on essential health benefits? So for example, can there be a limit of only 10 mental health office visits covered per year? So there cannot be any annual or lifetime dollar limits on EHBs. You can't say that you can only, or that the plan will only pay $1,000 toward mental health office visits. But yes, there can be other limitations, such as a number of visits that are covered per year, or a number of visits that are covered at like a specific cost sharing amount per year. Plans can also require a prior authorization for EHBs. However, these requirements can't be more restrictive than the state's essential health benefits benchmark plan. So there is kind of some cap on those restrictions, although it varies by state. The next question, do all plans with the same AV offer the same coverage? And I will kick that over to you, Arianna.
Do all plans that have the same actuarial value have the same coverage? No. That's going to simply be, again, that benchmark that's endeavoring to place them in different categories. But of course, plan design can be quite varied. Now, plans in the easy pricing standardized plan category, those would have the same plan design, but unfortunately, that's kind of a different category than actuarial value.
Okay, our next FAQ is something that one of you raised in the chat, but I'll go over it again. Do copays for pre-deductible services count toward the deductible? What about the out-of-pocket maximum? So copays for pre-deductible services do not count toward the plan's deductible, but they do count toward the plan's out-of-pocket maximum. And then finally, I will leave this for you to answer, Arianna. There isn't a plan in my client's area that covers their medications, preferred doctor, and that has premiums they can afford. What should I do?
I would say acknowledging that that's a difficult situation with the client is where I would start. I would say this does happen, and it's unfortunately something we're going to have to roll with. And I would say figuring out kind of an order of importance. Generally, medication is going to be pretty important, I would say. If, the medication is life-sustaining, etc., sometimes there's a conversation to be had about whether the client can take a generic medication or a less expensive medication. But often that's not an option. And thus, I'm going to say that's probably the number one thing that the client needs to not compromise on. On the other hand, monthly premium, if you can't afford it, and then you're no longer able to pay for your medications, it kind of wipes out the whole scenario. So the thing I would unfortunately put last would be the doctor, and what I might be advising and again, if we're talking about someone who's referring to their primary care provider and that's the person they prefer to see, but that person's not in network, seeing if there is another facility for which they can see a primary care provider. I would assume that they're seeing that person only a couple of times a year, whereas they're taking the medication every day, possibly. Um, so sometimes people are uncomfortable with that, but if you're having to, you have to sacrifice one of these things, unfortunately. Cost is usually not something, you can just decide to pay more if you don't have that money. And this medication, I assume, is something pretty important. So it might be that the thing you need to think about is ensuring you see that doctor before the end of the year while they're still in network, right? And work with that doctor's office to find someone else who's in network. You can, shop around as best you can. I understand this can be very traumatic for patients who've been with a doctor for a long time, but this is a reality of our system at the moment. And as best we can ensure that they're happy, they're healthy, and they're comfortable with their situation, the better. And I do think letting a client know, like, yeah, this does happen. This isn't unfortunately all that unusual. And that's what I'm here to help you figure out, right? As best you can. I hope that answers that question.
Okay, I think with the time remaining, oh, sorry, I keep saying that we're done, but then another question comes in. So this is a great one. I noticed you didn't highlight the medical management program filter. Does anyone use this, and what is the benefit? Ariana, would you like to respond to that?
Oh, yeah. To my mind, at this point in time, given the protections that the ACA has for clients, the essential health benefits, there can't be, for example, exclusions of asthma medications or, certain categories of care. I don't find that this is very useful. There are plans that still offer a quote unquote medical management program within certain categories. But honestly, there's no real distinction between the care someone would get within that and the care they would get without it. So, plans can no longer just exclude carte blanche categories of care. So, the need to look for a plan with a specific medical management system is kind of obsolete at this point. Now, I want to say that there is likely something I'm not thinking of here, but from a general perspective, I don't think anyone should be on the lookout only for a plan with a medical management component because they all should cover essential health benefits. That should not be a thing. And why it still is kind of beyond me, to be honest. I hope that helps.
Hey, thank you so much, Claire and Ari, and thank you, Lynn, for responding to questions in the Q&A chat. Here you can see the resources presented in the slide deck today. This is for plan design, and here we have resources for plan selection. We will be distributing the materials from today's session via email, and we will post everything to the Beyond the Basics website at healthreformbeyondthebasics.org. We have another office hours session coming up, healthcare.gov redetermination and renewal process for 2025. It is next week, Tuesday, October 22nd at 2 p.m. Eastern Time. And you can register for this and any other webinar we have coming up on our website under upcoming webinars. If you have any questions, please feel free to reach out to Claire or Arianna or email our general Beyond the Basics inbox at beyondthebasics@cbpp.org. So we're going to give folks just a few minutes of their time back. Thank you for joining us, and thank you to those who asked questions. So with that, I will bring the session to a close.